Welcome to the OrthoJOE Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Mark Swiontkowski from the Journal of Bone and Joint Surgery.
Morning, Mo.
Hello.
Cheers.
Morning.
I know you've had a very, very busy week in a new role at McMaster, and you probably do need a couple of cups of Joe before you get going today, but I appreciate your willingness to fit this into your busy schedule to chat this week on another topic in OrthoJOE. So we're returning to our format of just finding something of interest in a recent issue of one of our publications, and so I've got ours, and the lead article is one on a topic that has been of great interest to me, and I know you more recently, and that is the issue of unipolar versus bipolar in displaced femoral neck fractures in elderly individuals. And this is a study from the Australian National Joint Replacement Registry, a very large study, 62,875 patients with femoral neck fractures that were treated with primary modular unipolar or bipolar. And the outcome of interest was revision. And this has been a topic that's, it's been around since I entered orthopedics. I recall in my early days, we were still putting in Thompson prostheses, and then there came this new concept from Bateman, who I believe was a Toronto surgeon who developed the bipolar articulation with the thought that if you had a secondary articulation between a smaller head and a mobile, more larger head, that you would decrease acetabular wear. And we've had, probably hundreds of publications looking at revision rate with these two approaches, questions of, do the secondary articulation actually move, et cetera, et cetera. So this study in a very large number of subjects showed that in the first 2.5 years, there's no difference in the revision. But after that, the hazard ratio goes up to 1.86 in favor of a higher risk of revision for the monopolar versus the bipolar. And there are some other findings which are of interest in this. And so this is a topic that's of high relevance, given the fact that you and Dr. Tom Einhorn have recently published the health trial, which compared total hip to a hemiarthroplasty in displaced femoral neck fractures. And I'm sure there was both monopolar and bipolars in that group. So what can you tell us from that large RCT?
Yeah, and it goes back to a couple of big lessons we learned from that. The first one was when we were deciding total versus hemi, there was a lot of debate, a lot of expert opinion debate at that time. This is now well over 10 years ago about, what's considered a appropriate hemiarthroplasty in the treatment of patients with femoral neck fractures, displaced femoral neck fractures. Well, at that time, there was a consensus, for the most part, that a bipolar and a modular unipolar would generally be equivalent. So we just grouped them together as the hemiarthroplasty. What we didn't do was allow the monoblock hemis, so the Thompsons and the Moores. They weren't going to get in. But there was a real belief that there was no difference. And in fact, when we looked at overall, just looking at, in the first 2 years, there didn't appear to be a difference, even though we didn't, we weren't doing a tested randomized trial against the type of hemi. The first couple of years, we didn't see a big difference. In fact, the first couple of years, we didn't see a difference between total and hemi. But overall, we started seeing a trend. We started seeing that the advantage of a total hip replacement really starts happening beyond, it seems, the 2-year mark, where we start seeing the revisions associated more so with the hemiarthroplasty. And you're right, the acetabular component side of things were more concerning. The acetabular side was more concerning with the hemi. And we started seeing more revisions in that area. But it gets to that bottom line point. Our trial was maybe, just under 1,500 patients or so. Nowhere near the, tens and tens of thousands of patients in these larger registries. And our challenge always is we don't have randomized trials that, at least, follow patients for, decades, let alone, a couple of years. So those are going to always be push and pull of trying to understand evidence when we're trying to understand hip fractures.
Well, the real issue in following this group is that the age of the patients that are have the condition of question, right? I mean, in this registry trial, the mean age was 80 and 81 in the two groups.
Oh,
so
yeah, right. And the same thing.
It's not going
right?
to have
Even,
10-year follow-up, right?
Oh, for sure. And the same thing happened in the health trial. Health trial, our population was allowing patients, 55 and older with a what we're calling a fragility fracture or low energy fracture. The average age of patients enrolled in the study were mid-70s. So
Right.
The reality is one can argue, well, is this truly generalizable to the younger patient in the 60s, for example, with a femoral neck fracture? We don't know. But These trials are typically further on. And you can also make the argument too, Mark, that the following, that even if it suggests that bipolar is better than modular unipolar, there is a cost associated with a bipolar.
Sure.
In an 88-year-old individual, and you're with potentially a 2-year life expectancy or less than a 5-year life expectancy, one could argue, you might just say, in this case, we know the evidence suggests there's no difference, and maybe the alternative here makes sense to using modular unipolar, even though this study would suggest, hey, bipolar has a better longer term,
Right.
Longer term revision risk. It may not make sense in the individual case.
Right. Yeah. Well, that's what we're always doing as surgeons, right? We're taking the evidence as it exists today and applying it to an individual patient and family and making those kinds of judgments, because we'll never have the perfect trial for anything that's going to answer all questions. As a matter of fact, somebody might ask you, why didn't you in the health trial include other arms, meaning the bipolar versus the monopolar? Why didn't you do that? And it gets to the whole issue of practicality, right? With what we have to do to be able to get the numbers to answer questions.
That's exactly right. And, some of it is just the pragmatics of funding a multinational trial, which is expensive. And the second one was, there was generally a belief at that time that the hemiarthroplasties, modular, unipolar, bipolar, were functionally the same. So, there was just, not the insight. So when you get these large data sets that help you, it does make a big difference. The one thing that I know Dr. Harris has been doing and talking to is these large platform projects where you can collect lots of data, as you can here, but he's also been speaking quite openly about building in nested randomized trials within the context of a registry or within the context of some of these larger databases. And you can argue, if you're already collecting the information and you have an easy way to get the outcome, which is revision, if it's being collected, let's say, nationwide, you can imagine that randomizing, could be much easier because the hardest part of the trial is to get the patients to be followed and get, reliable outcome data.
Right.
You can see how that could work really nicely. And we saw that a lot in COVID, right? We saw lots of platform programs come out where they weren't looking at a single study, but multiple studies, multiple different questions on the same platform.
Right. Well, I know that Ortho Evidence has really done a great job with following the evidence in treating COVID. So what can you learn? What can we learn from what has been out there as far as the way the international community has approached this pandemic in terms of data sharing and developing novel ways of assessing the influence of various vaccine approaches, et cetera?
Yeah, and I think it goes back to the pressure points. We learned more than any other time in history, at least recent history, that we can actually conduct very large studies and get answers relatively quickly when there is a full concerted global effort to answer a particular problem. So when someone says we are going to put lots of resource to determine which of the 15 different potential treatments work for COVID-19, it became relatively easier to say we no longer have a barrier to getting trials up and running. Financial barriers are gone because governments and other groups are funding this work. Right. Everyone in multiple countries is now invested in getting this information. And by the way, it's their number one priority. So it's happening really quickly. We would have never seen the number of trials. There were like 600 trials in first phase, March 2020, Mark, that were being run. And a lot of them were platforms where one group was saying, for example, in Oxford, for example, they were running a platform, which was the Solidarity trial is a platform trial, which was multiple different programs, all being on the same, and the same groups are testing it through a pragmatic design and a rapid design and a moving things forward very quickly. So that kind of mindset, I think, would be ideal for a non-COVID environment as well.
So just capitalizing on using the same data platforms and the same way of posting data and collecting data in an organized manner with cooperation between multiple centers.
Yeah, absolutely. And and the truth is that it still costs real money and it costs real time and real coordination. So it's not like this, that it's some sort of easy alternative. It's a really hard alternative to do, but it's one that makes sense. The other thing we should be doing a lot more of is having data at our fingertips. So for example, we should never have to spend time looking backwards when there's a crisis or a new problem. We should have a repository. We, in let's say medicine, we often look at, let's say, Cochrane. The Cochrane reviews have been putting things together. But the truth of the matter is the Cochrane reviews are still representative of a single paper and a single outcome. So you still have to search papers. There has to be a way to get data. Yeah, we got to get data into a system that allows us to, out of, snap of a button, be able to pull information out so you can drive trials going forward, right? That's, I think, where, I see the future going. And I think many ways, these large data collection groups and platforms are thinking the same thing.
Yeah, well, that's one of the goals of the collaboration between OrthoEvidence and JBJS is ultimately we'd like to get there someday in our professional life. Absolutely.
Well, I mean, if you think about where we're going, and we are diverting a little off of hip fractures, but we are in a digital age, right? And so when we talk about digital content is gold. And but just having digital content is not helpful if you can't find a way to get meanings from data. And I think in many ways, what we're seeing in these larger data sets is, as it's easier in one way because things are precise, but it's also dangerous another way because it's precise. And precision doesn't mean it's accurate. It just means that you have such narrow confidence intervals that you can start believing all kinds of things now show up.
Right.
How do you make sense of which one's right and which was wrong? The fundamental challenge with a registry will always be there in that patients are getting allocated treatments based on preferences of a patient or preferences of a surgeon, and trying to balance that never after the fact with statistical analysis can never make up for the primary attempt at trying to randomize. And that's always going to be the push and pull of these sort of programs.
Right. Well, there are some many other valuable things in this manuscript that support clinical decision making. The one that stood out to me was the fact that the use of cemented fixation really did decrease the risk of revision, regardless of which head was used. And that supports what other clinical trials have found. But in the end, the decision-making around revision is subject to clinician bias in a registry format. And I think all of us would have a lower threshold to revise if a patient had a monopolar versus a bipolar.
Sure.
It's just, that's the way we roll as surgeons. But I think the future of answering questions like this to a much greater degree of precision lies in the development of these international networks with platforms that we can share and run multiple trials off that. And since I'm so much older than you, I'm going to be watching in my retirement as you develop those platforms and answer these questions. So I'm going to look forward to it. And maybe,
well, it's very kind of you to say, but I think I've already got people, way already ready to do it because I don't feel that young these days. This is my third cup, before, in the morning, so it's taking me more and more fuel to get started. But anyways, it's all good. It's all good.
Yeah, that's good. Well, great to chat with you again, Mo, and we look forward to the next discussion. And I think next time it's your topic. So
I'm gonna find some real good stuff. I'm gonna find some real good stuff.
Yeah. Cheers.
Awesome. Cheers.
Bye.
Cheers.